Sawasdee krab. Good evening from Bangkok, and good morning, good afternoon, all participants from around the globe. Thanks for joining us on PMAC session 207, Immediate Health Response to COVID-19, a test for health system resilience. Tonight we have a great panelist to discuss and talk about the issue on hand that concern everyone at the moment. Of course, it's been almost a year, but we still try to figure out how to make our health system more resilient. And hopefully this session gonna provide some insightful thought and discussion that help you, keep working on this important matter. My name is Bowan Somliapan. I'm an assistant professor from Mahidol University in Bangkok, Thailand. And tonight we have a great panelist. Let me introduce them very quickly before we go over the discussion. Firstly, we have Dr. Kathleen Arsenault from Harvard T.H. School of Public Health. She was recently lead research at the Lancet Corporate Health Commission on Health System, High Quality Health System, I'm sorry. And recently leading a 15-country project on the indirect effect of COVID-19 on health system performance using the administrative data. So we're going to learn a lot from the real analytical of the real empirical data, how health system resilience performed comparing many other countries. Secondly, we have Professor Sundar Rahman Thiagarajan, or maybe I'm gonna use his first name from now on, Sundar. He's a global coordinator of People Health Women, or PHM, in India. And he has worked in developing community health workers program in India for a long time, and also other different aspects of health system strengthening as a part of the National Health Mission. We are so glad to have you here, Sundar. Next, we have Ms. Nikki Gurley from the PATH organization. She's doing monitoring, evaluation, and learning right there. Also, her current work is focusing on immunization, malaria, and health system training in low and middle income countries. Again, Nikki, welcome to have you here. Last but not least, we have Dr. Ren Minghui, the Assistant Director General for Universal Health Coverage and Communicable and Non-Communicable Disease at World Health Organization headquartered in Switzerland. Dr. Minghui currently represents WHO on the boards of the Global Health Fund to fight HIV/AIDS, TB, malaria, also on UNAIDS and UNITAID. Once again, welcome to have you here, Ren. Unfortunately, we also have another speaker, Dr. Edwin Barasa, who cannot join us tonight, but maybe we have more time to discuss about something he would like to speak on tonight as well. So, without further ado, I'm going to go over very quickly on the next step of how we should start the conversation if we think about health system resilience. So maybe we can go over some conceptual framework and measurement of health system resilience very quickly, and then start the conversation right away. If you ask, what exactly do we mean by health system resilience? If we consult the literature, actually some people talk about it in the literature, especially after Ebola outbreak in West Africa several years ago. Hannafield and colleagues thinking about health system resilience are drawing from the system science literature. So there are many people talking about system shock and learning ability. Of course, system shock is something that impact greatly on the system we care about. And hopefully we learn something to prevent the system shock or reduce the negative impact of system shock. If we compare that to the health system literature, basically it's the governance, right? So maybe there's something to talk about the governance and how good governance can play a role in building up, strengthening health system and build up a health system resilience during the COVID time. Edwin Barasa, who cannot join us today, actually have a paper talking about health system resilience actually as software, not the hardware of health system. So that's kind of aligned well with the idea of health system governance. there's many types of health system resilience if you think about it from that perspective, like plan resilience for the future crisis. But sometimes we need to adapt it after the real crisis happen, and maybe not everything can be planned. There's also something called everyday resilience or for routine and chronic states in health system. So maybe there's something to think about it. How could we cope with something we can plan and we can something we cannot plan? Carl Blanchett talking about the three stages of health system resilience. If we can break down into some sort of degree of tolerance and change that health system can endure. For example, if maybe the stress is not that big, we have our absorptive capacity, but the more crisis arise, maybe the more adaptive capacity we need, and eventually the bigger system shock, maybe the change really need at a structural level, maybe we need a transformation. So there's something to think about, that maybe health system resilience is not just going back or bounce back to the old places before the crisis happened. Maybe we do need to transform our health system to a better place than when before the COVID-19 started. And last but not least, there are many people try to measure health system resilience. Margaret Cook, our professor at Harvard School of Public Health, is one of the author who try to do that. Maybe we already have something in our health system literature, talk about awareness of the capacity and also the risk of the population and how to communicate those risks. Diversity of the intervention that we have to deal with the crisis, and how much self-regulation within the health system, the integration rather than fragmentation of health system, and of course, last but not least, the adaptability of the health system. So more or less, we still try to figure out, try to figure out what is exactly the health system resilience. And that's before the COVID-19, right? When COVID-19 happened this year, there's a lot to be learned about what actually health system resilience mean for all of us. So maybe I'm gonna turn to the panelists to try to answer those questions. How do we understand health system resilience across the developed and developed countries? And maybe what are the roles of leadership and governance and other global health architecture like WHO can play this role? And perhaps at the end of this session, we can synthesize some lessons learned to tackle not just this COVID crisis, but other future catastrophic health event should that happen. So maybe I'm going to turn to our first speaker. Kathleen, please.
Thank you, Ak. So today I'd like to introduce to you a project that I have been working on at the Harvard School of Public Health, along with Professor Margaret Cook in the Department of Global Health and Population. So this project is called Health System Performance during COVID-19. And so I'll be going over project aims, give you a brief overview of our methods, and then it's very preliminary, but we have some results and preliminary conclusions from 6 countries that I'd like to discuss with you. So this project has 2 aims. The first one is more of a descriptive aim. We want to look at what's happening with health system performance nationally and subnationally before and after COVID. So we're interested in seeing whether COVID-19 has affected health system performance, health system resilience. And the second aim is more of a causal one. We want to look at the effect of COVID intensity, as well as COVID-19 containment policies. So we're talking about travel restrictions, curfews, things like that, whether they have had an effect on health system performance. And we're defining health system performance with 3 categories of indicators. First is the utilization of health services. So this is the volume of services provided, how many patients are getting care for a range of health conditions. The second is quality of care, and the third is institutional mortality. And so, sorry, these arrows are misplaced, but our hypothesis is that the COVID-19 pandemic may have an effect on reducing the number of people getting health services. It may also have an effect on reducing quality of care for certain reasons. And we are also expecting that COVID-19 may have an effect on all-cause mortality in health facilities. So right now we're working with collaborators from 13 countries, 11 low and middle income countries and 2 high income countries. These 13 countries are distributed fairly equally across Latin America and the Caribbean, Africa, and Asia. And so what's really interesting and novel with this project is that we're using HMIS data and routine administrative data sources to assess our outcomes, so health system performance, volume of services, quality, and mortality. In several of these countries, we're able to access this data through the WS207 platform. And in other countries like Mexico, Chile, and Thailand, we're using another form of health management information system, so another source of administrative data. And in most countries, we're trying to access facility level data at the smallest level of aggregation. In others, this is not possible, so we're using province level analysis. And so in terms of our exposure, we're interested in COVID cases and deaths, as well as the containment policies. So these containment policies are being tracked by a team at the Oxford University, and we're complementing this ourselves. So in terms of the methods that we're using, the first thing we need to do with HMIS data is to do a thorough cleaning. As you know, these data are self-reported by health facilities, so they may contain some errors, some outliers. So we're identifying and removing those. There's also an issue often with delays in reporting and completeness, which is affected. So we've developed some protocols to clean the data. And we're collecting these data over time. We started with data from January 2019. And we are expecting to continue extracting the data until January 2021. So we're still kind of in the middle of this project. After cleaning the data, we've created some dashboards which help us look at trends in services, quality, and mortality. And we're trying to develop some policy briefs to allow ministries to take action in real time. After that, once we finish extracting data, we're going to be conducting some more advanced modeling, most likely using interrupted time series methods. But so today I have results from 6 countries that we can look at to try and start figuring out what's going on with health systems in these countries post-COVID. So these countries are Mexico, Haiti, South Africa, Ethiopia, Nepal, and Thailand. So let's start with Ethiopia. So Ethiopia had the first COVID case in mid-March, March 13th. At the end of March, the country declared the state of emergency and instituted a few containment measures. This graph here shows the total number of antenatal care visits in the country, as well as the total number of children who came in for care for pneumonia. And this is data from DHIS2. And what we're seeing in Ethiopia is actually that most indicators are pretty stable. The thicker line here for each indicator is data from 2020. So we have in this graph data until August 2020. And the thinner line is 2019. So we're able to just compare directly what happened for each month in both years. And so in Ethiopia, we're actually finding stable trends, but we believe that this is probably a combination of both a decrease in utilization in certain regions, as well as an increase in reporting since last year, because the DHIS2 system in Ethiopia is fairly new. When we disaggregate the data by region and by urban rural, we're finding that urban areas do have a big reduction in services. And we also saw that hospitals appear to be more affected. So in Haiti, the first COVID case was end of March 2020, and the country implemented a few containment policies immediately at the end of March. This graph here is showing the total number of diabetes visits and hypertension visits. So people who came in for these two chronic conditions. And what we're seeing in Haiti with data up until June is that there's a downward trend in pretty much all the services we assessed, we were able to collect in the DHIS2 platform. We're also looking at mortality indicators from the DHIS2, and we found that maternal and perinatal mortality have increased considerably post-COVID. So in South Africa, we are working with KwaZulu-Natal University. So we have data from that region specifically. The first COVID case in the country was in early March. Since then, we've seen a sharp decline in April for pretty much all services except antiretrovirals. And we've seen that some services have resumed, but not others. So for example, this graph is showing total inpatient admissions as well as diabetes visits. So we're seeing that there's the thicker line at the bottom shows that these two services have not really resumed yet with data until September 20th, 2020. We also see that most institutional mortality has increased, particularly maternal deaths. So this is data from Mexico, and I put a star to indicate that this is from the Mexican Institute of Social Security. So this is the public health system that covers about 60% of the population of Mexico. The first COVID case in the country was at the end of February. And since then, we have observed a downward trend also in utilization of most services and a reduction in quality. So in Mexico, we were able to get some great quality indicators. We also see in the graph that some mortality indicators have increased. This is emergency room mortality in pink. So we're seeing a sharp rise, which pretty much matches, I think, the COVID outbreak in Mexico. And we also saw maternal mortality at the bottom, which has doubled since COVID started compared to last year. But one finding that we cannot really explain yet is that at the same time, we're finding stillbirths and newborn deaths have decreased. So in Nepal, the first COVID case was in late January. And what we saw is that from January to March, there was a sharp decline in most indicators, which was followed by a quick resumption in services in April, May, and June. This graph shows vaccination of children, BCG and Penta 3. We also found that maternal deaths have doubled in Nepal, according to the DHIS2 system, and stillbirths are stable. Finally, in Thailand, the first COVID case was in late January, and there was a series of containment measures implemented in late March. We only have a few indicators so far in Thailand, but what we're seeing in this graph is that outpatient visits have declined substantially in 2020, starting from February. And unfortunately, in Thailand, we haven't been able to access mortality data yet. So here in the slide that I added, I tried to start comparing what's happening in these different countries to try and identify patterns. So I use one indicator, which is the total outpatient visits, which was available in every country. And I compared quarter two, so April, May, June 2020, compared to April, May, June 2019. And we're seeing kind of a range of effects. In Ethiopia, there was only a 2% difference between the 2 years. In Nepal, it was only a 3% difference. But then it goes all the way up to a 32% decline in outpatient visits in KwaZulu-Natal. I also added at the bottom urban regions in Ethiopia. There are 3 regions which are predominantly urban. And in these 3 regions, we're finding a 31% decline. I also added the country income group in the graph and also the total number of COVID deaths as of June 30th, 2020. And so far, we're not really seeing any kind of patterns in what's happening with health systems during COVID. Of course, Mexico and KwaZulu-Natal had the worst outbreaks among these 6 countries, and they do have some sharp declines in essential health services. But for example, Ethiopia, with only 103 COVID deaths by June 30th, has seen some large decline in urban areas. So what can we conclude so far? Of course, we haven't done the full modeling and the full analyses yet, but we're seeing already that a lot of services have declined in these countries since COVID-19. We're also seeing out of the 5 countries that report maternal mortality, we're seeing that 4 countries have shown a drastic increase in maternal deaths. And it's still unclear why. Perhaps women are arriving too late to health facilities with complications, or perhaps quality of care has been affected in health facilities. And then our conflicting results is that at the same time, we're seeing stillbirths are either stable or have decreased in several countries. We're also seeing that urban areas and hospitals appear to be more affected than rural areas and other smaller health facilities. And of course, these findings should be interpreted in light of the data limitations. These graphs in several places have been created using only a subset of facilities that report consistently throughout the 2 years of interest. COVID-19 could have also affected data quality and reporting. So this is something that we have to look out for. And finally, mortality data in these routine data sources has not been validated. And there may be some places where this data is not accurate or mortality is underreported. So we're hoping that this project is going to generate lessons for future health system shocks. We are hoping that we will be able to identify certain containment policies that may have had stronger indirect effects on health systems, and to identify also which services are most affected in these times of crisis. And so we're hoping that these findings will contribute to the development of policies to improve health system resilience. And finally, this project will also demonstrate the importance of DHIS2 and these routine data sources for addressing health system resilience, since in times of crisis, this is the only data source that we have access to, given that surveys are interrupted and things like that. So finally, I'd like to thank my collaborators from these 6 countries, as well as the team at Harvard, which have made this project possible. Thank you.
Thanks a lot, Kathleen. Right. It's a great start to think about health system resilience from academic perspective and how the routine administrative data can reveal some, insightful signaling of actually what's trouble out there. So I guess it's not just only the COVID cases of and the death, that we kind of concern very much on early in the year, but thinking broadly in terms of healthcare utilization or even mortality from other cases, that's going to be defined at least one of the dimensions of health system resilience that we should be defined. So maybe we can discuss a bit further on that, the framework of health system resilience, but not just from the outcome perspective, but also the process and what people have done in real health system. Next week, we're going to have Sundar talking about his work and how that would be related to health system resilience in South Asia. Please, Sundar.
So thank you for this. It end of the year allows us to wrap up a whole lot of work on around COVID-19. So this is hopefully the last webinar in a series of webinars since across the kind of world now. So let me just start with saying thanks for this invitation. There are many definitions, and earlier speakers have referred to two of them, Joanna's and Margaret Cook. But if I may say, the one that is particularly relevant to us in both developing nations especially, is that health systems resilience is the capacity of health actors, institutions, and populations to prepare for and effectively respond to crisis. This was the earlier one, but maintain core functions when a crisis hits. So you could see Catherine emphasizing the loss of essential health services and informed by lessons, reorganize if conditions require it. And the important point is it needs both a public health response and the proactive, adaptive healthcare delivery. So it's not this or that. Therefore, resilience is a property of the system as a whole rather than a single dimension. So I think both of these have been summarized in the introduction and in the last presentation in some detail. So I'm not going into it, except to say that though I borrow from this, we needed to go beyond to think of our own framework in a way in which we could use it for making change rather than a static assessment on one particular area on that. So the framework that we have used, because it's a number of studies, about 10 studies that we have done over this various period, which we are putting together in this, is that a resilient healthcare system is less disruptive of social and economic life. You can get a COVID control by disrupting the entire lives of millions of vulnerable people, like you saw in the migrant crisis in India. That's not a mark of a resilient system. A resilient system should do this much less damage. And this is particularly important because social security systems are very weak. Unorganized workers are the majority. And if your crisis cannot cope with that, it does not much help. The second is less disruption of essential health services. This was already explained in some detail by the earlier speaker. The third, of course, is what he was calling as COVID intensity, less case incidence and case fatality from the epidemic itself. And then learning and adapting to new situations better. And the question of equity in the response and consequences. At some point, if we are talking of state response, we are really talking at some whether they have been able to reach out to marginalized sections who are far more vulnerable. Now, in the conditions, the preconditions are looking at adequate financial resources and adequate human resources. But for a number of reasons, we are really looking at measurement of resilience of a particular system. The purpose is to compare and make changes and improve. Then it helps to look at key design characteristics for each of the building blocks. I'll explain why that is important on that. Let's look at one particular strategy that has dominated the scene, the strategy of lockdowns, what has come to be known as lockdowns as a public health strategy. Immense across the board social restrictions. These nations of South Asia and Pacific region have been organized on the basis largely depending on cases per million and deaths per million. If I've gone by cases per million, you can see deaths per million parallels it, but goes above and below. The ones in brown are middle income countries, and for comparators, I've kept two at the bottom, which are high income countries. And you can see that the stringency of social restriction measures have been highest in India and Nepal, but their incidence of cases and deaths per million have also been very high. Whereas you have relatively much lower. So the Q3 stringency in India, which is measured by this Oxford Government Reference Index, so it looks at different closures, different elements of intervention. You can see that at the lowest Q3 is still higher than what was in Q1 in many countries, which like Thailand and Vietnam have managed a much better control. And therefore, this relationship between the stringency of control, social measures, and cases. Therefore, one of my first preliminary statements would be that resilient systems respond with limited disruption of social and economic life. The game is really of being able to control the pandemic without having to create mass unemployment, starvation, nutrition, deaths from tuberculosis, rising maternal mortality. So resilience can't be described only in terms of the pandemic response, but in terms of the disruption on a much larger scale. And this is one particular point. And this lockdown has come to mean a terrible thing for India's poor. And it has been a terrible thing across the world. It also means a militarization of the state. It means a violation of human rights. It means a setting that is created which is extremely undemocratic and dangerous on that. So in some sense, the first real goal of a resilient system should be to limit the disruption of social and economic life. The other is in relation, let us look at the preconditions on that. And here we have a simple point to make, that the higher the absolute health expenditure and the greater the degree of financial protection, the less likely you are to have a pandemic and the better the control. So if you look at Sri Lanka at 50% out of pocket expenditure, Thailand and Australia and the Japanese and the Vietnamese relatively much better levels of financial protection, you are having a much better outcome in terms, and this is the same ranking. So the ones on the top 6 are below the average in terms of COVID-19 performance. The ones below are are better than the average. So you can see that those that were doing relatively poorly on COVID-19 control have actually lesser degrees of health expenditure. But between the group, if you look at between the first 5, there can be variations. But it doesn't compare, for example, with the next group of the middle income or the high income country. The same thing for financial protection. Now, both of these are represented in 2 other preconditional but are systemic pre-requirements, which is the health professional. This is the sum of doctors and nurses per 1,000 population, beds per 1,000 population, and ICU beds per 1 lakh population, 100,000 population. And you can see that Australia, Thailand being a country, even Sri Lanka, would be much better off in some of these indicators as compared to the countries which do very poorly on that. So this is one broad thing that we can arrive at. So we can say, in terms of summarizing the preconditions of resilience, that nations that do spend more on health do better. Nations that have more financial protection, nearer universal coverage, will do better. Nations that have higher densities of a human resource, they will better. These are all intuitive statements, and that have more investment at all levels of care, including ICU beds, do better. But within subgroups, by financing and HR deployment, the variation from this norm could depend on what we call design characteristics. Why does Australia and Japan compare? How do you compare the relative performance of this? The second thing is, what do countries which are very far off from the UHC do? Because they are anyway got structural constraints. What does it mean for them to become more resilient? And here is one thing before we proceed further on statistics. Here's a recent, in fact, yesterday's data, November 15 data, and look at the cases per million and the states across the country. Now, there is a curious inverse relationship. Very clearly, the states which are the best performers in health systems in terms of the traditional indicators of infant mortality and maternal mortality, and known by many, many other parameters to be very good performers. So we are not saying that the RCH parameters are misleading. They are quite correct. Tend to have the highest number of cases per million and deaths per million. Whereas if you look at the last 5, the last 6, of which the 4 big states, Rajasthan, Madhya Pradesh, Uttar Pradesh, Bihar, account for close to 40%, 38% of India's population, they are really the worst performers on maternal mortality and infant mortality, but figure as the best performers on cases per million and deaths per million in COVID-19 intensity and control. Clearly, there's a problem in basing our advice between these states on the basis only of these indicators. And at some point, we have to move to a different way of looking at it, because we do know that Kerala has had a very good control relatively, especially in the early stage, and has still a relatively low mortality. And you compare with international indicators, it does well. But it's at a different level of health systems maturity. So it's misleading, and states with a low universal access and UHC is a distance goal. So we need to look at design characteristics. So what we start looking at is which of these states had less disruption of essential health services, which had more affirmative action to reach poorer sections, which overcame well-known barriers in public health measures and access for vulnerable people in COVID-19 care. And this, we looked at case studies across states and on nations to look at the organizational principles. We can learn a lot from best practices. Now, I'm not going to be able to describe each of these best practices, but I'll just highlight some of the processes that emerge from looking at 3 nations and also looking at interstate comparisons on that. And many of these are not the whole state. It's not that Nepal did very well, but a particular place called Biratnagar in Nepal had a particular hospital that managed these problems. So the case studies are not, which I'm quoting from, are not country-wide case studies. They may be sub-national level case studies on that. So clearly, nations which had a wider package range of care were able to maintain essential services much better. So if you had to go all the way to the district hospital or medical college for non-communicable disease, it was not part of your primary care package. It was unlikely that you could make it now. Continuity of care between levels, a number of strategies that played out made a huge difference. Some did with this, some did not. Telemedicine is talked of, but not so much the game changer as the question of stocks, logistics, home delivery, task shifting, and things like that. Closer to community, higher community engagement, more community health workers, more diverse community health workers tended to do much better. The overall surge capacity within the system, the inbuilt redundant capacity tend to do better. And finally, private sector provisioning does not relate, it does not really hold up. The proportion of public sector delivery, we are not talking of purchasing from the public sector, we are talking of publicly administered service delivery, tends to have a better, because it closes down less and it is able to sustain much better under the circumstances on that. And therefore, this is the issue that we will really take on. Health information systems, again, have certain specific design recruitment. The DHIS2, for example, does very well because it allows decentralized use of information for action. It is able to be controlled at subnational levels, and there are ways in which you can use that. But the problem in many of these is that the security apparatus, the Home Department, takes over much of the surveillance function and much of the function related to disease surveillance, and it does not understand or care to actually look at the surveillance system. For example, flu surveillance systems existed, but they were dropped and rather than built upon to capture the COVID-19 epidemic because the administration that took over did not have the connect. So therefore, there is this whole set of issues about design characteristics of health information systems. Similarly, on access to technologies, good public health logistics for a huge number of things. Look at the immensity of problems in reagent stockouts. People have really looked at test kits, but don't look at reagents. Are very, very limited in supply and very difficult. And large countries have a huge problem. And scaling up domestic production. Bangladesh, for example, was able to scale up on a number of items. India was able to scale up, but it took time, and the ability to scale up is sensitive to both domestic policies and international regimes. The other characteristics is human resources. Now, here I differentiate between human resources as a precondition, where we are largely talking about numeracy, but we are talking the numbers which are minimum densities, but we are talking of two features: how system supports the health worker and how system cares for the health worker. So systems that were very rapid in reassuring them, giving them protective equipment, revising guidelines, training them, and had a less precarious service and more secure services tended to do much better than others which did not have. And this is in comparisons within. And the provision for sick leave and breaks is important. The protection for family against stigma, the sense of the team and public service. And many of these places reported specific programs to address mental health problems that health workers face. So which kept them on the job rather than the drop in. So Nepal, for example, I saw it in the earlier presentation also, by April had bottomed on its immunization. But by July, August, it had pushed back and it had actually gone to 120% with a catch-up of lost immunization. And finally, in governance, there are 4 features. Decentralization did great wonders in Nepal. There has been lessons from Kerala. There are many issues. Learning adaptive systems. We have a paper on the Nipah virus and how the tackling of Nipah virus helped Kerala deal much better with this. But you also have from other countries on the SARS virus. Then affirmative action. And here there is a big point to be made. Demand, there is a latent demand. The needs of the poorest section may not be expressed. Anyway, they have not been attending NCD care. They have not been going for a whole lot of infections, multi-drug resistant. It's not likely that they are going to turn out for COVID-19 care. And therefore, when the whole systems are closed, they are the ones who are less likely to make an effort to reach the hospital. So typically places which went all out to inform the public that, listen, our services are open, please come. We have not closed down our essential services, did well. But there were other hospitals which were happy to announce that because of COVID-19, we have closed down all the services. Only COVID-19 patients will come. And there's a serious issue in the ethics and legality of repurposing very busy essential public service hospitals for dealing with the pandemic. Because you threw out a whole lot of patients for catering to a very minimal patients, and these patients really had nowhere to go, very much against equity on this. And there were a whole lot of design or issues on this. So I close with this particular issue. But there are a number of studies which over the year we've drawn from. I particularly point out this one on pandemic resilience, on good public health logistics, and this comparison of the South Asian region under CRO of maintaining essential services, best practices on them. And some studies that we've looked at on learnings from the Nipah virus outbreak and the whole issue of public goods, and where the public provisioning itself makes a huge difference, as different from market-based, even purchasing of care. So there's this whole areas that we've put together for this. Thanks for the opportunity.
Thank you, Sundar. I think you raised a lot of good questions and good point on to be discussed furthermore, particularly when we shouldn't just measure health system resilience in terms of death and morbidity from COVID-19, but larger impact on socio-economic life of the people, right? And then maybe precondition like USC or other strength of building block is quite important, particularly in terms of processes to deliver care to the target population. I guess we need to compare and contrast between not just countries in South Asia, but also to other countries as well. Fortunately, we have Dr. Edwin Barasa to join us here. We thought you couldn't make it, so perhaps we're gonna have the perspective from another academic, but from African perspective. Dr. Barasa, please. By the way, you have about 10 minutes. We ran a bit late than expected, so sorry about that. Go ahead, please. So perhaps we're gonna more of the practitioner from an international organization, NGOs and authority like World Health Organization, right? And then, so Nikki, please, could you share some experience from, from the perspective of international NGO working in COVID health system, please?
Thank you so much. So my name is Nikki Gurley. I'm an MEL officer at PATH, which is, as Dr. Ak said, a global NGO. And I'm here today to talk about a policy analysis that we did earlier this year, examining the maintenance of health services during COVID-19. We've called this project the COVID-19 Essential Health Services, the EHS Policy Tracker. So how did we get here? PATH is a global NGO working across 70 countries, and we became interested in this question of what is the policy response to COVID, as many of our colleagues around the world in March and April were supporting national governments to develop national guidance and policies to support the COVID response. The work I share with you today is from our Health System Strengthening and Policy and Advocacy Division, which examines policy development and supports implementation. So Catherine spoke to this extensively in her presentation, but COVID has disrupted the delivery of essential health services in many countries to varying degrees. And routine data collection has really revealed a wide range of impacts: missed immunization visits, interrupted supply chains, excess mortality, and more. And we know that the reasons for the disruptions are myriad. They include supply side factors such as facility closures, as well as demand side factors such as a fear of going to facilities. And where we sort of became interested and engaged in this is that in the short term, the maintenance of EHS is really critical to absorb and adapt to these shocks. Knowing this, we examined what is the policy response specifically aimed at maintaining and adapting these essential health services and really building and bolstering resilient health systems. So, based on what we were hearing from colleagues globally, we launched what we called the COVID-19 Policy Tracker. This is a PATH project that was done in collaboration with WHO and funded by the Bill and Melinda Gates Foundation. And the objective of the policy tracker was really to catalog and synthesize what are the government policies specifically on the maintenance of EHS during COVID in order to really understand what is the policy response and enable more informed decisions. Several panelists have made reference to containment policies, such as curfews, lockdowns, movement restrictions that have been used as public health measures. Those policies are not included in this analysis. This is specifically looking at health policies and policies designed to maintain services. So to achieve this, the product we really created is a policy tracker dashboard. And what we did is we searched for policies on the maintenance of essential health services across 119 countries and 115 essential health services. Policies were solicited from local ministries of health, technical partners such as UNICEF, and implementing partners. The policies cover a wide range of documents, including national policies and strategic plans, but also operational guidance and guidelines. We ultimately found 198 policies through Q3 of 2020. And what we then did is we coded the policies to examine what did they recommend. Did they recommend adapting services? Did they recommend maintaining services with infection prevention control and PPE? Or did they recommend the suspension of services? With this coding, what we've done is we've created a dashboard that shows all of the policies, which can be interacted with and explored at the link you see here. You will notice we only have policies in 53 countries currently. Some of the limitations we encountered included language of the policies. We currently code English, French, Spanish, and Portuguese, as well as just simply access to documents. Not everything is publicly accessible, and there are instances where countries don't have policies, perhaps because of a low COVID burden. What I'm going to focus on for the rest of this presentation is what are some of our preliminary learnings and takeaways from this policy synthesis. So the first thing I would highlight is at a high level, we really saw that governments acted quickly to introduce policies and to develop policies that protect health services. On the left, you can see in black is the number of cases, is the number of policies introduced over time. On the right is the number of COVID cases collectively. And you can see that broadly, policies were developed in advance of rising case counts. What we saw sort of initially looking at the policies is that much of the national guidance mirrors WHO guidance. And you can see that the March 25th WHO policy introduction, the first vertical line here, really did spur further policy development. Given this, we hypothesized that much of this policy development was really driven by the strength of the existing global health architecture, and in particular, the WHO guidance and health advisor networks. The other key piece, of course, is wanting to understand what these policies contain. So how do these policies mitigate or exacerbate disruptions to essential health services? And what we saw broadly is that of the 198 policies reviewed, the majority recommend the continuation of services or the adaptation of services. 59% suggest adapting a health service, 58% suggest continuing services with either PPE or infection prevention control. And then a minority of policies, 11%, suggested pausing or suspending services. In general, the services that were recommended to be suspended or paused tend to be in one of two groups. One, they were either community-based delivery of services, such as a school-based delivery program, or they were elective or non-urgent surgical care, such as male circumcision. In general, this is very much in keeping with the WHO recommendations and guidance around maintaining essential health services during COVID. So I mentioned at the outset, these very much are meant to maintain health services, to absorb that initial shock from COVID. However, you can see from the large number of policies which contain adaptations, this also presents a potential opportunity to transform health systems to be more accessible, equitable, and resilient. And so what we examined is, what are the delivery adaptations that are mentioned within these policies, and what is their potential to transform health systems? We see a whole range of adaptations. I'll talk through these very quickly, but on the farthest left, the first column, we see adaptations that are really geared at limiting patient density in health facilities, things like appointment scheduling or extended service hours. If we move to the right, we then see models of care that really limit the number of visits a patient has to make to a facility. Things like integration at point of care to reduce duplicate visits, task shifting to community health workers. Continuing moving to the right, there are also interventions that limit face-to-face contact, telehealth, self-care by patients. And of course, there are also then interventions that emphasize equity. So planning for people who are missed out on services, prioritizing those who are more vulnerable or are likely to be missed. And then there are also adaptations which ensure continuity of services, particularly medication. So things like multi-month prescribing, commodity delivery. Many of these are interventions and adaptations that have existed prior to COVID. I'm sure many of these are things that you're all very familiar with. But what we've seen is that many of these have also been newly elevated and prioritized as a result of COVID and the need to respond to this shock. And in this way, the response to COVID really presents an opportunity to transform the health system and accelerate uptake of these adaptations. So the other thing I want to highlight is, we of course all know that policy recommendations don't always translate to action. A recommendation may not be feasible, it may not be implemented, or it may not be effective. And several speakers have noted the importance of core health systems dimensions to resilience, sort of the software of the system, elements like financing, governance, health workforce. So in addition to coding the recommendations for what they recommend for service delivery, we also examine the policies for mention of health systems building blocks, these cross-cutting operational components that really help actualize policy recommendations and speak to systems resilience. What we found is that the majority of policies focus heavily on service delivery, the bar at the top, and that really captures the recommendations I've already discussed, adaptations, continuation of services. But policies give less descriptions to the health systems building blocks that really enable the process of delivering these adaptations. So for instance, Sundar mentioned the importance of logistic systems, the importance of access to essential medical products and technologies. You can see this is fairly far down the list, with only 33% of policies mentioning how do we access medical products and technologies. Similarly, financing and sustainability, which are really critical if we want to think about transforming the health system more permanently, are mentioned only in about 11% of policies each. And so this presents a gap when we think about the process of policy implementation. I just want to conclude with sort of an example of this, a case study of this using telemedicine. Telemedicine is one of the more commonly recommended adaptations during the pandemic, as it has the benefit of maintaining services while reducing face-to-face contacts. And ANC is a common example for where telehealth is recommended. You can see the WHO guidance suggests telehealth consultations should be used when possible. The challenge, of course, is then in operationalizing. So a recent publication on the use of telehealth during COVID, we see a minority of providers actually report having started adopting telehealth since COVID-19. 1% of providers report newly using it in low-income countries and 16% in middle-income countries. And these respondents really identified a number of barriers. Some were technological, such as poor literacy of technology or poor access, perhaps not having a mobile phone. Some are financial, not having access to the internet or not having phone credits to conduct the call, as well as just challenges with the platform itself, a lack of nonverbal feedback or distrust from patients. For us, this really reinforced two key points from this case study. So despite policy guidance, there are still barriers to the adoption of these adaptations and best practices. And secondly, these barriers also reflect, as others have noted, that we have to pay attention to sort of the equity implications of these innovations as well. For instance, in telehealth, a key concern is the access to the technology needed. Those without mobile phones are at risk of being left behind. Ultimately, we came away from this policy synthesis with three key lessons. So first is that there really was a rapid response and initial policy development to absorb and adapt to these COVID shocks. Secondly, these policy recommendations really do contain adaptations which build us towards longer-term transformation. And COVID has the potential to accelerate uptake of these innovations and adaptations. However, further work is needed to continue responding to COVID and to continue building resilient systems for future shocks. Specifically, we see a need to rapidly evaluate adaptations to identify what is most effective and feasible so that resources can be directed to the most high impact interventions. Secondly, there's a continuing need to ensure that policies are translated down to the lowest level and implementation is really supported with governance, financing, staffing, and more. And then lastly, with an eye towards long-term transformation, there's a need to really sustain and institutionalize these adaptations and best practices in order to transform health systems and foster long-term resilience. Great, that is all from me. Thank you all.
Thanks, Nikki. You pointed out quite important issue that transformation just couldn't happen in the vacuum, but we also need a very strong building block to do so, and that's how policy can be operationalized to action, particularly on transform the healthcare delivery using digital health or something like that. So perhaps because you mentioned digital health in Africa, it's nice to go to Edwin and talk about his experience, not just on the operation, but also the analysis from a broader African perspective. Edwin, please.
So my name is Edwin Barasa. I'm going to quickly talk about, reflect on COVID-19 and health systems resilience, giving some reflections from Kenya and Africa, from the African continent. So I think we've gone through this severally in the course of today, which is thinking really about what is health systems resilience. I like to look at it as, a health system is considered to be resilient when they have reduced vulnerability to and better prepared and effectively respond to a crisis. So on the one hand, you have reduced vulnerability, you're better prepared, and you can effectively respond to a crisis, while at the same time being able to maintain the delivery of core health services. So that's how I like to look at resilience. And I think this was shared again earlier by the chair of this. We did a literature review a while back to look at what exactly do we mean by health systems resilience and how can it be nurtured. And a couple of things came up. Some of the things that came up from the literature review was the need for health systems to be prepared. So preparedness and planning was a key component of health systems resilience. Having resources was quite important. How health systems manage information. So thinking about things like surveillance, information flows, analytics of routine data like DHIS data and so on came out as being quite important. Collateral pathways. So collateral pathways is really just about ensuring that the health system has alternative ways of doing the same thing. So alternative ways of supplying key commodities, alternative ways of delivering services. We've heard, for example, about using telemedicine when you are unable to have physical contact with patients and so on. So building redundancies within the system was shown to be one of the key ingredients to health systems resilience. Governance processes, so coordination, response, decentralization, leadership practices, investment in human capital, so not just numbers, but also thinking about health worker motivation, for instance, their skills and whether they have appropriate tools to be able to deliver on their work, and social networks and collaboration. So the ability to be able to tap in to networks, to draw on resources to be able to respond. So thinking, for instance, about being able to tap in to the private sector, being able to tap into regional government, if you're a local government, or to international and regional bodies, if you're a state. So these are some of the things that came up as important for health systems resilience. So a quick look at how COVID-19 has played out in the African continent. The first case of COVID-19 appeared in the African continent around March of this year. Generally, so we have 54 countries, so there's a lot of variation across the countries. But generally, there was a peak around June, July, August, and then there was sort of something of a second peak towards the end of the year. And in some countries, the peak is continuing, and in others, like in Kenya, for instance, the second peak, the second wave is peaking once again, so infections are going down. But then when we compare the cases with what we see in the rest of the world, then you see Africa is much lower there. So compared to other countries, we are seeing much lower cases. When you think about deaths, we've had quite a number of deaths in Africa, but again, compared with the other regions of the world, Africa is at the bottom of the pile with regard to number of deaths. So essentially, the pandemic in Africa has been characterized by very high levels of asymptomatic infections, low cases of severe disease and hospitalization, low cases of deaths. And there are many things that have been put forward to try and explain these, including the fact that Africa is the youngest continent. So the average age is about 18 years compared to countries, regions like Europe, where the average age is 34, 35 years. So in many ways, the pandemic in Africa can be characterized as a silent pandemic, in the sense that we have lots of infections, but severity and deaths are not as many as you'd expect in other regions of the world. How has the African continent responded? In varied ways. These are just examples of measures that have been implemented by the African continent. And when you look at the Oxford government response stringency index, you will see that there's variation across the African countries, but generally African countries responded in a stringent way, so implemented quite a number of measures, but there is variation. So you have countries like South Africa, for instance, which implemented very hard lockdowns. You have countries like Kenya, which implemented moderate measures such as curfews as opposed to lockdowns. And you have countries like Tanzania that essentially denied that COVID-19 exists, so did not implement any measure. So a lot of heterogeneity across the African continent, but generally there was a strong public health response. So the general assessment of how Africa responded from a public health response perspective is that Africa responded in a timely way. So the measures were implemented quite early on in the pandemic. Before the pandemic hit the country, there were airport screenings, physical distancing restrictions were introduced, borders were closed, and so on. And this is said to have arisen from lessons that were drawn from other pandemics, such as the Ebola pandemic, for instance. So in as much as the public health response was strong, there's a sense in which the health system response was not as strong. So this is a table that compares testing capacity across different regions. And the general message is that testing in Africa has been quite low compared to other regions of the world. When you think about, the health system capacity to respond, so availability of essential commodities such as oxygen, PPEs for health workers, motivation of health workers. When you think about, for instance, availability of equipment for availability of intensive care facilities and equipment, it has been low. So in Kenya, for instance, we have only about 537 ICU beds at the beginning of the pandemic, with only 22% of the Kenyan population living within 2 hours of an ICU. So the health system response, in a sense, has been unlike the public health response. It has been quite a weak health system response. We said earlier that when you think about resilience, you're not just thinking about responding to a pandemic, but you're also thinking about whether you're able to maintain core services. So like the presentation that used DHIS data, so routine data, we also looked at routine data in Kenya, for instance, to look at the extent to which, if any, the COVID pandemic has disrupted service delivery. And what we find in Kenya is a mixed bag of results. So generally what we see is that around March of this year, there was a reduction in, for instance, per capita outpatient visits. But the reduction largely remained within expected ranges. So there was a reduction and then an upturn, but it remained largely within the expected range. TB case detection is another example where there was a large dip around March when COVID restrictions were introduced, but then it has slowly started coming up. So the general finding really has been that there was a disruption in March. It wasn't as much. And then immediately after, service delivery started trending upwards towards normal levels. There has been a terrible effect from a socioeconomic standpoint. So this slide, for instance, shows the trends in sexual violence cases that are reported in health facilities. And you can see that from March of this year, there was a huge spike in cases that hasn't gone down since then because of COVID-19 restriction measures. Across the continent, when you think about other socioeconomic impacts, so for example, economic impact, it's been estimated that 50% of existing jobs are going to be lost in Africa, that a lot of people working in the informal sector are vulnerable and will lose their jobs, and about 49 million people are likely to be pushed into, or rather 23 million are likely to be pushed into poverty in Africa as a result of COVID pandemic and response measures by African governments. But the continent has, again, there's a lot of variation across the continent in terms of response to mitigate socioeconomic impacts, but there are certain commonalities. So African countries have established solidarity funds, their safety net programs. Some countries have introduced reduced taxation or tax holidays, introduced cash transfers to vulnerable people, food distribution, temporary employment programs, and subsidies for small businesses. But the one underlying thing about the socioeconomic measures to mitigate socioeconomic impact has really been the limited fiscal space for these measures to be implemented at scale. So while they have been implemented, there have been challenges to reach all the vulnerable that should benefit from them. A good thing that has come out of Africa has been essentially strong regional coordination and leadership at the regional level by the Africa CDC. So the Africa CDC has been very, very instrumental in sharing information and coordination, development and dissemination of guidance and response, and mobilizing resources and coordinating pooled procurement for some essential commodities, such as reagents, for instance. So that has been something positive that has come out of the response in Africa. So I will end by additional reflections on what the COVID-19 experience has meant for those of us that have been thinking about health system resilience for a while. And one of the reflections is essentially the fact that we need to be thinking about whole of society resilience rather than just health system or healthcare system resilience. So tearing down arbitrary boundaries that seem to characterize the resilience narrative in the global health space. So thinking about, for instance, tearing down the distinction between public and private, and ensuring that there is adequate engagement of both the public and the private sector. Because what we found in Kenya, for instance, is that the public sector, the infrastructure in the public sector alone is not sufficient to respond. And so for countries to adequately respond, they're going to have to engage with and engage with the private sector. Thinking beyond just curative facility-based care and emphasizing and promoting preventive and promotive care is quite important. The dichotomy between facility-based care and community health care. For instance, it became quite evident early on that Kenya was not going to be able to respond, to have adequate capacity at the facility level to provide care for COVID-19 patients. And a decision was made to provide home-based care for patients with asymptomatic mild to moderate disease. So if the community health system was not going to be used in a country like Kenya, then facility-based care wasn't going to be adequate to respond to the pandemic. And then also thinking about research systems versus health systems. One of the things that has been quite clear over the past year is the important role that research has played in terms of providing evidence for response through modeling, for instance, the COVID pandemic and so on. So ensuring that there's adequate integration between research systems and health systems is quite an important thing to think about for resilience going forward. Outside of the health sector, thinking about multi-sectorial approaches, the public health response that we keep talking about are implemented by actors beyond the health sector. So thinking about the transport sector, security, education, housing, urban planning, social protection, all of these are important sectors that contribute to a pandemic response. So whole of system resilience requires thinking beyond just the health sector. Thinking about social determinants of health, for instance, it has become quite evident that vulnerabilities such as the number of people living in informal settlement, the proportion of homelessness, poverty, inadequate water and sanitation, disability, gender defects, and so on, contribute to country vulnerability to the COVID pandemic. Then, of course, community resilience, recognizing, supporting, and leveraging on bottom-up community responses. So, for instance, in Kenya, when people were asked, a survey was done to ask people who do they remember helping them out during the COVID pandemic, and the organization that comes up at the top is a community-based organization rather than the government or big organizations like the World Bank and WHO and so on. So recognizing the role that community mobilization and community-based initiatives play in enhancing the resilience of systems and societies is quite important. Then there's a thing to be said about cognitive capacity, and here it's really about what sources of knowledge are recognized and how do we make sense of our problems. One of the things that became evident during the African response is the fact that the pandemic in Africa has played out in a completely different way from the way it's played out in other countries. And so measures that were implemented in other countries are probably not, cannot be copied and pasted in the African context. And so really thinking about recognizing local voices and local solutions to problem has been something that has been brought to the fore during the response to this pandemic in Africa. And then, of course, thinking beyond hardware, so thinking beyond finances and health infrastructure and so on, and recognizing the important role that leadership and governance plays in the resilience of health systems. A lot of you are now familiar with the famous, or should I say infamous, listing of health security or global health security index, where countries like the United States, United Kingdom, and European countries and so on were ranked as being higher in terms of health security. While in reality, what we see is that these are the same countries that have suffered the most from the pandemic. Thank you.
Thank you, Edwin. That's a very clear articulation on how we can approach health system resilience, not just in Africa, but I think you pointed out that the context is very important, right? The part dependency that you guys experienced Ebola outbreak last time, and perhaps the African CDC is a good context in this case. Well, that's linked to our last speaker. Ren, you have a very tough question to answer after having heard practitioner, researcher, policy analytic thinking and talking about is what can WHO and its global health governance infrastructure architecture can do about it. Please.
Okay, thank you, Dr. Act, and thank you very much for the invitation to me to join this very important discussion on the health resilience. Today, I would like to convey three key messages. First, the disruption caused by COVID-19 pandemic demonstrates the centrality of health to economy and social development, global security, poverty reduction, equity, and human rights. Second, the unprecedented revolution in health innovation resulting from the pandemic provides a platform for building back better and more resilient health systems. And third, the failures in global health governance must be addressed through renewed commitment to multi-sectoral collaboration and multilateralism. Let me elaborate respectfully. First, In less than 12 months, the COVID-19 pandemic has profoundly impacted global public health, security, and development, as we hear from all the speakers. As for today, over 67 million cases has been confirmed worldwide, affecting 220 countries, areas, and territories. Over 1.5 million deaths has been reported. Fragile health system has been devastated. Most essential health services being disrupted, resulting in excess deaths due to the other diseases and health conditions, along with increased mobility and hardship. These disruptions are threatening disease control and elimination efforts, while we might have very clear consequences for the year to come. The Pulse survey conducted by WHO in May and June this year assessed the impact of COVID-19 on essential health services in 105 countries. The greatest impact was experienced in low and middle income countries, particularly in Eastern Mediterranean and African regions. Those regions already challenged with fragile health systems. Most frequently reported disruption were to the services for dental care, rehabilitation, immunization, diagnosis, and treatment of non-communicable diseases, family planning and contraception, treatment of mental health disorder, malaria prevention, and antenatal care. 46% of malaria endemic countries reported disruption in malaria diagnosis and treatment. HIV testing was disrupted in 62% of countries. Cancer diagnosis and treatment was adversely affected in 55% of countries. Modeling by WHO and partners indicates that 50% of drop in TB case detection over 3 months will lead to additional 400,000 deaths worldwide, taking us back to the mortality rate lasting in the year 2012. Most disruptions has been driven by the weakness in the basic foundation of health systems, notably at the primary and community health care levels. Access to services has been hindered by lockdown, disruption to the transportation, closure or repurposing of health services, and financial harness experienced by families. Large numbers of health workers has been deployed to the emergency services. Hospital beds were fully occupied with COVID-19 related case, and many specialist services has closed. Manufacturer capacity for the essential medicines, personal protective equipment, and other health commodities are being stretched, and the procurement, supply, and management systems are falling. Not surprisingly, the poorest and most marginalized individuals and community are the ones most affected. Lockdowns and unemployment for those with no social or financial protections are catastrophic, resulting in homelessness, increasing in gender-based violence, and stress of food insecurity, which probably you see the data and finding from other speakers. Second, these challenges has been met with unprecedented actions, driving innovation and investment, not only to respond to the existing crisis, but to look forward to the short and midterm future. The urgency of COVID-19 crisis has leveraged advances in research, basic science, clinical practice, service delivery, communication technology, manufacturing, partnership, and financing. Never before have we seen such international and multi-sector collaboration and cooperation to accelerate the development of novel vaccine diagnostics and therapeutics, which should benefit all other diseases and better prepare us for the future threat. We're also seeing innovations in health service delivery and the rapid adoption of services. We have seen the countries respond by expanding, task shifting, and decentralizing services, adjusting the supply of medicine, including through the multi-month prescribing and community dispensing, promoting self-testing or community-based testing, investing in digital technology, including telemedicine, removing users' fees, and expanding communities' outreach. Most solutions strengthen and streamline health services that can deliver people-centered care benefiting multi-diseases programs at the same time. WHO has developed operational guidance for the country to help them to adapt their essential services during COVID-19 pandemic and to make them more agile for the future. Clearly, even before the pandemic emerged, the world already off track to meet most of targets outlined in the 2030 Agenda for Sustainable Development. The global public health commitment and target are daunting, and global health development architectures has become even more complex to address these multi-challenges and demands. Over the years, we have been alert to the potential impact of disease outbreaks on global development and security, such as HIV, SARS, MERS, Ebola epidemics. This threat has mobilized international cooperation and multi-sector actions and global solidarity. So my third message is the COVID-19 pandemic has introduced a new complexity and a sense of urgency that necessitates a critical analysis of health emergency response and the global governing mechanism. The international health regulations of WHO, we call HI in short, is the main instrument for global governance of health security, which is first adopted by the World Assembly in 1969. It's direct international collaboration to prevent, detect, control, and provide public health response to the international spread of disease while avoiding unnecessary interference with international traffic and trade. Key obligations for the country are to establish effective monitoring and early warning systems to rapidly report any outbreaks to WHO, to apply travel restriction when required, and to proactively share information. The rapid evolution of COVID-19 pandemic has highlighted significant elimination in the articles of current version of international health regulation and the broader health security measures. It has also demonstrated the lack of a preparedness of most countries to respond and effectively act. The unprecedented impact of pandemic has elevated COVID-19 pandemic well behind the scope of HI framework, the demanding global solutions through the exceptional multilateral actions. The pandemic has dominated the old agenda of most global development and security governance structures this year. We see many discussions in G20 and UN Assembly on these very important issues. But the commitments being made now needs to be translated into the country actions and sustained well behind the emergency phase for this COVID-19 pandemic. WHO has developed a dedicated COVID-19 preparedness and response plan and operational guidance and tools for the country to address the immediate crisis. At the same time, following the resolution by the World Assembly in May this year, the World Health Organization Director General established an independent panel for the pandemic preparedness and response to evaluate the world's response to COVID-19 pandemic. The findings of this evaluation will be presented to the World Assembly in May next year. It is anticipated the recommendation of the panel will have the profound influence in guiding the reform of international health regulations, WHO strategy, structure, and the broader global health security architecture. The pandemic is also shaping innovations in other aspects of global health governance, generating the enhanced cooperation, strong collaborations, and innovation partnership for COVID-19 related research, response, and financing. Notably has been established of the Access to COVID-19 Tools Accelerator Initiative, a new global collaboration to accelerate research, development, production, and active access to COVID-19 diagnosis, therapeutics, and vaccines. These initiatives has mobilized the unprecedented levels of cooperation across public, private, and community partners. We must ensure these new architectures and the culture of collaboration, of solidarity, has a lasting impact on health security, even when the pandemic is well behind us. A reformed public health security architecture must prepare us for an uncertain future. It must prioritize multi-sectoral partnerships that can protect us from future health threats, but also to tackle current health challenges. We must nurture the partnerships that will address the key determinants of health, prevent the emergency of new pathogens, enable the effective functioning of global and local early warning systems, reward and rapid transparent sharing of critical information, facilitate timely and equitable deployment of new medicines and technologies, support people-centered care services, build community trust, and reorient the health financing for sustainability. The pandemic response must be embedded within the broader health and development agenda and the governance structure. Already existing global health governance structures and mechanisms should be leveraged to build back better, more robust and fair systems. Building back better requires a whole of society efforts that promotes a One Health approach. WHO manifestos for healthy recovery from COVID-19 calls for such multi-sectoral actions, including protection of nature, investment in safe water and sanitation, and the transitions to clean energy, the promotion of sustainable food safety, building of healthy cities, and combating pollution. Building back better will demand new global and domestic investment in essential public health functions and multi-sectoral actions that will defeat COVID-19, protect us from future health emergency, create healthy environment, and make universal health coverage a reality. People-centered services delivery through the primary health care and community systems should be the central to the new reality. At the same time, the communicable and non-communicable disease programs will need to be reshaped if they have to achieve their disease control and elimination targets. So with that, I thank you very much for your attention.
Thank you, Ren. I'm afraid I'm doing a pretty bad job in terms of time management. So I guess we have to skip the Q&A, but if any audience have any burning question, feel free to drop a question or email us. I think every panelist is willing to answer the question if it's worth to start the conversation doing this important job together after this session is ended. So perhaps I'm gonna have each of the panelists say some last message before closing. You know, perhaps looking forward, just like Len's talking about, not necessarily from the perspective of researcher, practitioner, policy analyst, or authority, but whatever you think might be benefit the audience, please. Maybe can I start with Kathleen?
Thank you, Act. I guess in terms of next steps, we look forward to having some more specific conclusions on the types of containment policies that have affected essential health services the most, and other findings like that that will be helpful for future global health emergencies. We'll have a series of publications also to come out from this project, including on multi-country papers on the effect of COVID, as well as on DHIS2 data quality. And we also look forward to, we're considering being able to share these dashboards publicly for other countries and ministries to be able to see what's happening with essential health services. Thank you.
Thank you, Kathleen. Sundar, if you please.
Yeah, thank you. I think across all the speakers were talking about that COVID-19, in that context, resilience does not limit to just COVID-19 management, but to management of essential health services and also the entire social and economic life. So I think the big take-home point for me is that it's not enough if we view vaccines as the global public good. There is a requirement to look at all of health systems as a global public good, and resilience is a feature of being able to take it to that thing. Because if you don't have this, then it disrupts not only your healthcare, but across that, and you can rise on a number of issues. I were very good papers, very informative. I hope we are able to put this together in some format and be available to a larger audience. I found it very learning experience myself. Thank you.
Thank you, Sundar. If you may, Edwin.
Thank you. I think from me, from the experience that we've had, the experience we've had here in Kenya, and the several analyses that have looked at the impact of COVID, especially on disruption of health services, what's become clear is that the effects of the COVID pandemic are not just short-term, but they're also longer-term effects. And so sometimes within the short period that we've had the pandemic, we might not be in a position to completely appreciate the impact it has had in terms of disrupting services and especially longer-term outcomes. So the call is really for health systems across the world to continue to be vigilant and to monitor over the long term, because we likely haven't captured the true impact on disruption of health services and health outcomes and the effect on health outcomes. Thank you.
Thank you, Edwin. It actually a marathon, right? So Nikki, please.
Thank you all. I think similar to what Edwin just said, that this is there are longer run disruptions and this is a marathon. I think similarly to me, it seems there is also an opportunity here for longer run transformation. I think many of the panelists have spoken to this opportunity and that this is accelerating adaptations. I think for me, that's one of the key questions is where do we focus our efforts here for these adaptations and how do we evolve faster and better?
Thank you, Nikki. And Ren, if you may add anything from your very well-rounded speech already.
I probably just say thank you very much for the invitation again, but clearly we have a sort of a consensus from all the speakers and panelists on essential health services who should be absolutely covered in the dialogue when we're talking about build better and systems resilience. And also, since I'm cover a lot in terms of governances, we're great to see how exactly sustainable financing should be covered and to be included when we're talking about the governances in health resilience issues. If we don't have financial systems, we can't build a sustainable system for any health systems. This is absolutely key message. Thank you very much again for the invitation. Yeah.
Excellent. Thank you, Ren. So lastly, I would like to thank our speaker, Dr. Kathleen Arsenault from Harvard School of Public Health, Dr. Erwin Basar, Director of the Cambridge Wellcome Trust Research Program, Professor Sundar Rahman, Taika Rajan from PHM in India, Dr. Ren Minghui, Assistant Director General for Communicable Disease World Health Organization, and Nikki Gurley, Monitoring, Evaluation, and Learning Officer from PATH. Thank you all and for all the attendance of this session as well. Hope you have a good day and good night from Bangkok. Bye-bye.